Okay, so our first speaker for this final segment of today is no stranger to us in the Department of Surgery, Dr. Cypria Arroyo. Basically, she's a vitreoretinal surgeon and medical retina specialist working as a retina consultant at Princess Margaret Hospital and Bahamas Vision Center. She completed a residency in ophthalmology and super specialty training in vitreoretina and medical retina at Maulana Azad Medical College in Delhi, which is a premier institute in India. Her key areas of interest include diabetic retinopathy, central serous chorioretinopathy, and macular hole surgeries. She has published more than 40 papers and reputed international peer-reviewed journals, contributed to many book chapters. Currently, she is leading multiple research projects across the globe, and in the last 3 months itself, she published 10 papers in very high impact and prestigious journals of ophthalmology. She is a reviewer for many reputed retina journals. Today, her topic, we're looking at three-dimensional choroidal surface contour mapping and pathology. Comparison with healthy controls. Dr. Aurora?
Good afternoon. My presentation is three-dimensional choroidal contour mapping in pathology and in comparison with healthy control. So this work received funding from NIH grant. So to give a basic introduction, since most of you are non-ophthalmologists here, choroid is the layer of the eye behind the retina, which supplies all the blood supply to the retina. And earlier, the only way to study choroid was through ultrasound and through ICG angiography, as shown in this picture. The vessels on the top are the retinal vessels, and the vessels at the bottom are the choroidal vessels. Sorry. And so the latest technology to study choroid is the OCT scan, which is shown here in the picture. This is called as enhanced depth imaging OCT. So the top is the retina, and at the bottom where we see this arrow is the choroidal thickness. So this is the inner choroidal border, and this is the outer choroidal border or choroidal scleral junction. 6-7 years back, I published a paper where I studied on EDI OCT or enhanced depth imaging OCT, how choroidal thickness differs in between diseases. Like on the left side is a healthy eye, and on the right side top, there is a central serous chorioretinopathy with increased choroidal thickness. And at the bottom is age-related macular degeneration with thinned out choroid. But what is still lacking is the surface evaluation. All the imaging studies evaluating a choroid are based on choroidal evaluation based on the OCT scan. However, nobody has evaluated choroid from like a bird's eye view or a three-dimensional view of the choroid. So the aim of the current study was to develop an algorithm for quantitative characterization of 3D curvature of choroidal surfaces, including inner and outer surfaces, and report a comparison between healthy and diseased eyes. In diseased eyes, we chose two extreme spectrums. One is the central serous chorioretinopathy, and the other is the age-related macular degeneration because of contrasting choroidal features in comparison to healthy eyes. CACR is known to have thick choroid and higher choroidal vascularity index, whereas age-related macular degeneration is known to have thin choroid and lower choroidal vascularity index. This was a retrospective study, and we included eyes in 3 groups with a known diagnosis of either CACR, AMD, or healthy eyes. We had defined inclusion and exclusion criteria. Basically, we excluded all the eyes with any other pathologies which were concomitant. And we also excluded eyes where a good quality scan could not be obtained. The image analysis was done, first of all, we did the delineation of choroidal inner boundary and outer boundary. So as you see in this picture, this is the choroidal outer boundary. So there are two methods of doing it. One is a manual method and the other is the automated. The automated method was devised by our group in a previous publication. And so for segmentation of choroidal outer boundary and inner boundary, we adopted a modified choroidal segmentation algorithm combining a validated deep learning and 3D smoothing methods for choroidal layer segmentation. Just to explain what the previous paper was about and what we used in this was, so on the left side, we see normal and diseased OCT scans. In the middle layer, we see how a manual delineation of choroidal inner and outer boundary is done. And on the right side, there is automated delineation. And so we obtained a dice coefficient of 98% between the manual and the automated methods. And thus we use that method in this study. So to evaluate the surface curvature changes on the choroidal inner surface and outer surface, we've performed quantitative analysis using widely adopted metrics, including the best fit spherical radius, Gaussian curvature, and mean curvature. Now, these parameters were evaluated on choroidal inner surface as well as the outer surface. Apart from that, for each of the surface, we divided each surface into 5 regions: central, nasal, temporal, superior, and inferior. And to facilitate the expert grading analysis and division into regions, we developed an in-house graphical user interface to do this. This is just a picture showing a graphical user interface. So the top layer is the choroidal inner boundary and the bottom layer choroidal outer boundary. And when we converted into 3D surfaces, this is how they looked, the inner and the outer boundary. And on the left side is showing choroidal thickness in various sectors. This is another example just to show this. So how did we make choroidal volume? Basically, normally the OCT scan which we do, we used 1024 of those OCT scans and layered it, stacked it one over the other, and converted it into an OCT volume in the computer. And then that OCT volume was studied from a bird's eye view to understand the choroidal inner and outer surfaces. And here, this is showing 3 representative cases in age-related macular degeneration, healthy eyes, and CSCRI. Now, this is showing, this diagram is showing how we divided the regions into central, nasal, superior, inferior, and temporal on graphical user interface. First of all, best fit spherical radius is estimated for the overall surface to understand the overall curvature of the surface. And then best fit spherical radius is computed for each point on the surface using a MATLAB file exchange. And we use these formulas. P minimum and P maximum. P is the principal curvature, principal plane. The minimum and maximum curvatures in the principal plane. And so this diagram is showing that if it's a spherical surface, then P minimum is equal to P maximum, and how it changes in various kind of surfaces. We did the statistical analysis. Broadly speaking, we use generalized linear mixed models to study interaction between choroidal inner boundary and choroidal outer boundary radius of curvature. These are our results. So we had a total of 98 eyes of 98 patients, and they were divided between healthy CSR and AMD eyes. These are the demographic features. And so this figure is showing our results that, so broadly, we see that the radius of curvature is maximum in central serous chorioretinopathy and minimum in age-related macular degeneration, whereas it's the opposite trend for Gaussian curvature and the mean curvature. So CACR has the least and AMD has the maximum Gaussian curvature as well as the mean curvature. And this is the same trend as choroidal inner boundary as well as the choroidal outer boundary. This is the same figure which I showed earlier. At this point of time, I just want to highlight how if the radius of curvature is low, which means a surface is steep. So we see that in age-related macular degeneration, how this is steep. Whereas in CSCR, when the radius of curvature is high, which means it's a part of a bigger sphere, which means the surface is flat. So this is what we see in central serous chorioretinopathy, inner boundary and outer boundary. This is box and whisker plots for radius of curvature, Gaussian curvature, and mean curvature, showing the statistically significant results and the p-values in the three groups. And this is at the choroidal outer boundary. So our results show that overall, the choroid was flattest in central serous chorioretinopathy and steepest in age-related macular degeneration. Radius of curvature was highest for CSCR at COB as well as CIB, and the reverse was true for AMD. In COB as well as CIB, radius is maximum in CSCR, followed by healthy, followed by AMD, and the opposite for Gaussian curvature, which again implies that the surface is most convex or most rounded for the AMD and flattest for the central serous chorioretinopathy. On analysis of different regions in CIB and COB, the radius differed significantly between each region in the groups. CSCR showed maximum radius of curvature not only overall, but also in each of the 5 regions, and AMD showed minimum radius of curvature in all the 5 regions at CIB as well as COB. Comparison of overall CIB radius versus COB radius showed a significant difference in CSCR group. Like within the CSCR, outer boundary and inner boundary was significantly different. Intra-group regional analysis showed that the radius of curvature was minimum for the central region in all the groups at CIB and COB. In CSCR at COB, this difference was drastic as the radius of curvature in the central region was 5 times lower than the temporal and superior region. It has been well established that choroidal thickness increases in central serous chorioretinopathy and there is vascular engorgement. When the choroidal thickness increases, there is dilatation in the hollow vessel layers and attenuation of the inner choroid. This is because of limited space for expansion of choroid. Choroid is now in CSCR, choroid is thickened not only in the subfoveal region, but also in the periphery, which makes it flatten because of the limited space available for expansion. Thus, the choroidal contour flattens in CSCR. Wide field choroidal thickness analysis in healthy eyes has revealed that choroidal thickness is maximum in the subfoveal area and decreases towards the periphery. This may explain a steeper contour of healthy eyes as compared to eyes with CSCR. So far, we've discussed the overall contour at CIB and COB in the 3 groups, but there were local variations in contour in each of the 3 groups also. The center had the lowest radius of curvature at CIB and COB in all the 3 groups. In other words, center was the steepest amongst all the regions within any group. A robust automated methodology of delineation of CIB and COB, followed by contour mapping, is the strength of our study. The limitations of our study include its retrospective nature and limited sample size. To conclude, our novel 3D approach to evaluate choroidal surface demonstrates that the contour of the choroid at choroidal inner boundary and choroidal outer boundary is flattest in CSCR and steepest in AMD. Central region was the steepest amongst all the regions in both healthy and diseased eyes. In future studies, we plan to evaluate the choroidal contour in various other diseases, including high myopia, as well as correlate the choroidal contour with visual function. Thank you.
Thank you for that wonderful presentation. I open up the floor to any questions. See if there's any in the chat. No questions at present in the chat. So I have a question, Dr. Aurora. So there's these 98 patients, one where they all done here in the Bahamas? And then the other question is, like, how do we prevent this choroidal thickening? That seems to be an issue.
Okay, so all these patients they are pooled database from many institutions. They are from India, from US. Some of them were my old patients. Some of them are my current patients. So we pool in all the data, and then the ones with the best scans, we try to evaluate this. Yes, choroidal thickening cannot be prevented. It is something that, for example, let's say it's in central serous chorioretinopathy, the choroid is thickened. The reason for choroidal thickening is inherent. And there are certain factors, there are certain risk factors such as type A personality, smoking, which can predispose a person to having central serous chorioretinopathy. But the choroidal thickness changes. It's not something that can be controlled, or it can be changed.
Okay, thank you for that. Again, I don't see any questions in the chat. Oh, okay, yeah, one just popped up. So is there any association with diabetes?
So choroidal thickness has been studied in diabetes, and some studies are showing increased choroidal thickness in diabetes, whereas others are contradicting and showing decreased choroidal thickness in diabetes. But definitely there are choroidal changes. There is choroidal vascular attenuation with increase in diabetes and hypertension, but the thickness can vary depending on other factors. So it's not like it increases or decreases in diabetes, but yes, it definitely changes. The choroidal parameters change.
And another question by Dr. Leville. Can this predict or adjust therapeutics?
Yes. So when we give medications or when we treat, then the choroidal thickness and choroidal parameters change. So in this study, basically, the surface evaluation of choroid has never been done before. The choroid, there have been a lot of numerous thousands of studies on choroidal thickness. So we know that with treatment, if the choroidal thickness is increased and we treat, then the choroidal thickness might reduce when the disease resolves. That is true. But this feature of evaluating 3D has never been done. So we don't know what the changes are. So that's why we're trying to study, normalize, and identify what the changes are, and study diseased eyes so we know what the differences are. And subsequently, when we treat the eyes, how the changes appear, that is what we're going to notice. But
Awesome.
Choroidal thickness and other parameters definitely change with therapeutics.
Awesome. Thank you again, Dr. Aurora. We really appreciate you giving us this presentation.
Thank you.
And we're going to move on now to our next speaker. Our next speaker, again, no stranger to us in the Department of Surgery. His name is Dr. Charles Lucas. Dr. Lucas recently returned back from a fellowship in Canada, Toronto, doing vascular surgery. And today he's going to talk to us about resource utilization for low extremity interventions in vascular surgeon-led endovascular suites. Dr. Lucas, the floor is all yours.
Can you see well? Thank you so much. Okay, so we'll be talking today about resource utilization for lower extremity interventions in a vascular surgeon-led endovascular suite. And this research was really done with the Bahamas and the Caribbean in mind. And I have no disclosures for this paper. I want to acknowledge Natalia Paris, who helped with the statistics for this study. There's a table of contents, and let's jump into it. A bit of background. Endovascular interventions are increasing worldwide. They seem to be more economical than open surgery, at least according to a few papers, but the available data is sparse and heterogeneous. Those in cost-sensitive environments may be excluded from the clinical and physical benefits of these interventions. Vascular surgeons are well positioned to promote adoption and are cost-conscious. They perform endovascular interventions for more appropriate indications and are more cost-effective than other colleagues, despite having sicker and older patients. The objective of this study was one, to analyze the utilization of consumables in a vascular surgeon-led endovascular suite, And then this information was shared transparently to the surgeons and their colleagues to realize some cost savings. And we'll talk about that a little later. This study site was the Sunnybrook Health Sciences Center, which is, if you don't know, the only accredited level 1 trauma center in Toronto, and has an excellent vascular surgery program based there. And this was part of their quality improvement initiative. All procedures were done by one of 3 vascular surgeons. The data was collected over a 3-month period and then reviewed retrospectively. All costs were expressed in Canadian dollars, and the total cost was the sum of the items open for use, whether they were used or not. There's a list of the items that were deemed consumables, and the cost was recorded. Excluded was IV contrast, in addition, medications and IV fluids. Now, diagnostic refer to angiograms only, and interventional procedures refer to angiogram plus therapeutic intervention. On to the results. Again, thank you to Natalia Paris for helping with the statistics. It was a bit above me. But we did review a total of 72 cases. About 90% or 64 were interventions, and about 11% were diagnostic only. This shows the total spend per doctor, divided into diagnostic and interventional. Again, there's a table showing the same information about total spend. The majority of cases were angioplasties only, but you can see we did a range of procedures through 3 months. Sorry. There's a table looking at the top 10 consumables by frequency, and then stratified by cost per unit. I just want to highlight the first item, which was the ProGlide, which is a closure device, and that significantly increased the cost of the procedure. It's something that in our setting we could actually avoid using or find a cheaper alternative. Again, this is just another table, how significantly it contributed to the overall spend. We also wanted to stratify based on the location. You know that aortic iliac disease is quite different from tibial peroneal disease, and the costs needed to treat it also varies. This pie chart shows what areas were treated by the specific doctors as a percentage of the total cases. And you can see that doctors A and B did predominantly SFA disease, followed by iliac, while surgeon C did a heap of aortic iliac disease. We know that treating aortic iliac peripheral arterial disease is quite expensive because of the use of stents. In our setting, we see a lot of tibial peroneal disease, and you can see it's much cheaper, and I think that bodes well for us. Again, this is another chart looking at the location of the lesion treated as stratified by the doctor or the surgeon. And this is an example of the cost sheet that was given to the individual surgeons. So they saw not only their costs, but the costs of their colleagues. And this comparison, and we'll talk about it a little later, has been shown to actually result in changing the practice and reduce costs for the institution. The weaknesses of the study would be that when we talk about costs, these billing and charges are unique to a department, and they reflect basically what's being negotiated between the institution and suppliers and distributors. This can lead to a lot of the conflicting data in the literature, as each individual circumstance is quite different. I think the strength of this study, and why I think we can reproduce it in multiple centers and right here in the Bahamas, is that during the study period, the main operating theater only had a C-arm, and all peripheral endovascular cases were done in this endovascular suite. And this perfectly, I think, replicates the resources available in most resource-limited environments. The 3 experienced vascular surgeons in question were quite cost-conscious, and this was ideal for modeling. And when we do the repeat study, which will evaluate their costs after a period of 1 to 2 years, we'll see if the cost savings are apparent, and then I think this would be more representative of the cost savings we could see in our neck of the woods. As I touched on briefly, Goldberg et al. Showed that by simply sharing these cost sheets with surgeons, they achieve significant cost savings, up to 70% in a range of vascular procedures. In conclusion, the differences between the mean cost of consumables was not significantly different amongst the vascular surgeons in this single institution study. The average cost was about just over $600 for a diagnostic procedure, and the average cost for therapeutic endovascular intervention was about 2,600 Canadian dollars, which is quite good. I believe that this vascular surgeon-led endovascular suite may serve as a benchmark regarding the usage of consumables, both regionally and internationally. And I think we can see the benefits of promoting transparent and public sharing of cost analysis to contribute to further cost savings. Now, relevance to us in the Bahamas. Well, these quality improvement initiatives are critical to reducing expenditure while maintaining surgeon autonomy. We don't want artists barked down for be taught on how to operate and how to use our equipment. I think surgeons need to take the initiative. This evidence can be used to galvanize support for stakeholders as instrumental in developing best practices. Definitely in collaboration with the Division of Vascular Surgery in Toronto, we intend to create some vascular surgeon-led endovascular suites right here in the Bahamas. This research has also prompted me to create an entity to promote cardiovascular education, promote collaboration between specialists, facilitate training of staff. I'm hoping that we can get some vascular trained nurses and other healthcare professionals, and also to interact directly with suppliers and end users to make sure that we have the best care for our patients. Thank you for your time, and I'll leave the floor open for questions.
Thank you, Dr. Lucas, for that presentation. I have a question. So how commonly do you see, let's say, individuals here in the Bahamas that have, we have a vast majority of them with diabetes and hypertension that have tibioperoneal disease that's amenable to endovascular intervention?
I think we have a lot of patients who will benefit from endovascular interventions. And there's a little thing I'm a little passionate about. We can offer them these endovascular procedures right here at home, and with good outcomes, I believe. Because you can have pure endovascular approaches, you can have open approaches, and you have hybrid approaches. And the field has basically exploded where there's so many choices available. Our difficulty is the limitation of resources, not the techniques that are available, and not the trained surgeons who can do the procedures. So I'm hoping that we can, as we get more training of support staff and more funding and resources, that we can extend these really great procedures and techniques to their general population. I think we also recognize that a lot of patients are older and they're ill. They're more ill than before. And these endovascular procedures hit a sweet spot where these people can be afforded care, where they would otherwise be deemed too ill for surgery or too high risk. So I hope that answers the question.
Yeah, thank you. Do you have any other questions from the floor? Okay then, Dr. Lucas, thank you again. And I look forward to some of these outpatient endovascular suites that you plan on putting together.
Thank you.
All right, so our next speaker hails all the way from family medicine, I believe. And her name is Dr. Sherry Longley Thompson. And today she's going to speak to us about falls in community dwelling older patients in New Providence, the Bahamas. Physician knowledge, attitude, and practices towards implementing appropriate risk fall assessment. Welcome, Dr. Longley.
Hi, thank you. Good afternoon. My name is Dr. Cherie Longley Thompson, and I will be presenting on falls in community dwelling older adults in New Providence, the Bahamas, physicians' knowledge, attitudes, and practices towards implementing appropriate fall risk assessment. I have nothing to disclose, and here is my outline. Globally, improvements in the provision of healthcare has led to an increase in life expectancy, whereby the 2019 World Health Organization reported there were 703 million persons aged 65 years or older globally, and by 2050, this will rise by 16%. As for the Bahamas, the elderly population increased to 7.5% in 2020, and average life expectancy increased to 74 years in 2019. However, with an aging population, we can also expect an increase in geriatric syndromes, which includes falls. Falls are defined by the American Geriatric Society as an event whereby an individual unexpectedly comes to rest on the ground or another lower level without known loss of consciousness, for which the risk, morbidity, and mortality increases as we age, and unfortunately, it is typically overlooked as a common, costly, and preventable public health problem. Thus, in 2012, the Centers for Disease Control and Prevention created the Stopping Elderly Accidents, Deaths, and Injuries, or STEADY initiative, which is an evidence-based fall risk assessment tool verified for use with community-dwelling older persons, and was found to reduce fall risk by 30% in randomized controlled trials. However, despite its potential to reduce fall risk, fall assessment is not routinely done by physicians, and this is due to a lack of awareness, deficient training, time constraints in clinical setting, and the general perception that falls are not a significant healthcare concern compared to others. This results in missed opportunities to identify and manage at-risk patients, hence the need for this study. For this study, articles were sourced using the search engines and terms listed here. Of 50 articles sourced, the 25 referenced were published in English, assessed the knowledge, attitudes, and practices of physicians, and focused on persons over the age 65. This study sought to determine physicians' knowledge, attitudes, and practices for conducting appropriate fall risk assessment in community-dwelling older adults within the public outpatient setting in New Providence, the Bahamas. The study was a cross-sectional quantitative design conducted in the country's capital within the public community clinics. Registered physicians within the public outpatient care setting were targeted using convenient sampling technique. Participants included were physicians practicing outpatient adult medicine and those who consented to participate, whilst excluding those that don't meet the inclusion criteria. Ethics approval was attained by the respective ethics committees, and a self-administered questionnaire was used to collect data with the voluntary informed consent of each participant. This data was entered and analyzed using the IBM SPSS software. On to our results. Of the 120 physicians approached, 96 completed the survey, giving a response rate of 80%. This study determined that the median age was 38.5 years. About 59% were female, 48% were family medicine physicians, and of note, physicians subspecializing were grouped to avoid identifying their individual responses. About 90% were employed by Public Hospitals Authority, and 42% were senior house officers. Up to 28% had 6 to 15 years of clinical practice, and 32% of participants were stationed at Princess Margaret Hospital. Also, participants mostly achieved a degree that was either DM2 or DM2 equivalent, and about 44% saw 10 to 25 elderly patients per week. Participating physicians declared their degree of familiarity with the CDC STEADY Initiative Fall Prevention Guidelines, where 2% were very familiar, 17% somewhat familiar, and 81% not at all familiar. A statistically significant, very strong relationship existed between the physician's specialty and their familiarity with STEADY, where a greater proportion of family medicine physicians and geriatricians were at least somewhat familiar with STEADY. Perceived barriers to performing adequate fall risk assessments were ranked from not at all inhibiting to most inhibiting, where lack of training, unawareness, and more pressing issues to address were mainly ranked as very to most inhibiting, whereas falls being too complex to address were equally deemed little or somewhat inhibiting. Contrarily, patients unwilling to discuss fall risk, physicians unaware of fall risk factors, and fall assessment not relevant to my specialty or practice were each mostly considered to be not at all inhibiting. The latter was the only barrier that had a statistically significant relationship with physicians, with physician specialty at a p-value of 0.003. Overall, 49% of physicians considered this barrier not at all inhibiting. However, physicians from various specialties by large considered this barrier to be little to not at all inhibiting, with only 7% considering it to be at least very inhibiting. Participants selected their perceived facilitators where CMEs or training workshops dominated at 91%, followed by supply of assessment tools in clinic, and only 6% suggested other facilitators, which are listed here. Concerning conducting fall screening, educating patients and referrals, on a scale of never to very likely, at least 72% were at least likely to change their clinical practice to incorporate evidence-based fall prevention recommendations. Participants indicated their extent of agreement regarding which specialists should be involved in fall interventions and routine screening. Represented by the number 5, participants mainly strongly agreed that family medicine physicians, general practitioners, and geriatricians should be involved in both fall intervention and routine screening. The frequency by which physicians performed specific components of the fall assessment was reported. Over 88% assessed for presence and control of comorbidities and review of medications at least very often, whereas vitamin D levels were either rarely or never assessed by 73%. About 17% of physicians declared they used evidence-based fall prevention recommendations, whereas the remainder equally either denied doing so or were not sure. Finally, of 92 physicians reporting their frequency of fall screening, about 33% screened on request. Statistically, the frequency by which physicians screened differed significantly by their specialty, where P was less than 0.001. Of those screening annually, as per the guidelines, 29% of family medicine physicians, 50% of geriatricians, and 33% of general practitioners did so. On to our discussion. From these results, we see the knowledge of participants is reflected in their practices. When compared to the literature at 17%, use of evidence-based recommendations about doubled what was reported by Jones and colleagues, whereas the degree of familiarity with the study guidelines at 19% was somewhat comparable to what was reported by Howland and colleagues. Still, with less than 20% of physicians using evidence-based fall prevention recommendations, considering most participants having a DM level training or higher in this study, we can appreciate that geriatric fall prevention needs to be emphasized more in clinical training. In this study supports the notions that general practitioners, family medicine physicians, and geriatricians are the gatekeepers in community medicine for older adults, as these physicians were shown to be most knowledgeable and thus most consistent in their practices of evidence-based fall prevention. This idea was strengthened further by the physician's extent of agreement for which specialists should be involved in fall intervention, where physicians from other medical disciplines and even other family medicine physicians, geriatricians, and general practitioners strongly agreed that they should be responsible for routine fall screening and intervention. Overall, with responses ranging from strongly disagree to strongly agree, the median for physicians' responses regarding each medical specialty involvement in fall intervention was mostly agree and strongly agree. With fall screening, the median was at least neutral for the very specialists chosen. Furthermore, with the majority of physicians being likely to change their clinical practice and 80% at least agreeing that their clinical practice should incorporate fall prevention, where interestingly, when looking at responses according to medical specialty, gynecologists along with surgery and medicine subspecialists were primarily at least neutral in their responses. We see that the attitudes of physicians towards geriatric fall prevention were mostly positive, and the possibility of strengthening a multidisciplinary approach seems promising. Concerning barriers and facilitators, we see that the main barriers reported were similar to the literature. To overcome these challenges, CMEs or training workshops followed by the supply of risk assessment tools were the main facilitators recommended by participants. However, because it was not deemed feasible, more time in clinic and smaller patient load were the least recommended, and this attitude was also highlighted in an article published by J.L. Demons and colleagues. Therefore, further recommendations should aim to ease patient burden and promote efficiency in the clinic setting. Finally, concerning relevance of fall assessment to one's clinical practice or specialty, the response was mainly positive, with only 7% of participants declaring lack of relevance to be a significantly inhibiting factor, whereas the remaining participants by and large declared it was little to not at all inhibiting, with 45 to 100% of physicians from each medical specialty giving such ranking. This can be interpreted to mean that physicians from multiple medical disciplines appreciate the relevance of fall prevention to their clinical practice. Presence and control of comorbidities, along with review of medications, are common practices to the majority of medical specialties. Hence, they were the most consistently implemented fall assessments and interventions performed. The literature establishes multiple comorbidities and causative medications as high-risk factors. Thus, optimizing patients' chronic conditions and reducing polypharmacy are essential to reducing fall risk. Strengths of this study includes a high response rate compared to others. Also, this is the first study locally to assess physicians' knowledge, attitudes, and practices on fall prevention in community-dwelling older adults. Furthermore, once published, the study has the potential to sensitize physicians and contribute to local and regional research. The study was limited by financial and time constraints, which inhibited access to Family Island physicians, whereas the ongoing construction and closure of clinics, along with the challenge of busy clinics, impacted participation of local physicians. The researcher recommends the following. For now, we can refer all older persons at risk of falls to a specialist for a full fall assessment, commence CMEs and training workshops, encourage improved clinical documentation, and in the future, initiate a geriatric fall clinic involving the necessary staff. In conclusion, the results of this study establish that evidence-based fall prevention assessments and interventions are neither well known nor routinely practiced by our local physicians for reasons in keeping with the literature. We also determined that these physicians are willing to change their clinical practice and are in favor of fall prevention. To adequately address fall prevention, it is critical for healthcare providers to acknowledge its importance, be adequately trained, and be equipped with the resources and supportive staff to manage its complex nature. This is all in hopes to empower our elderly patients with the knowledge and resources to potentially reduce the incidence of falls. The CDC Study Initiative Toolkit is a verified resource to help bridge the gap and achieve our goals. I would like to thank Dr. Pinda Butler, Dr. Rivers, and Dr. Frankson for their assistance with this study, and all of my participants who helped with this study. Thank you for your attention. These are my references, and questions are welcomed. For your reference, this is the algorithm for the CDC Study Fall Guidelines.
Thank you, Dr. Longley. I appreciate that talk on falls in the elderly and our attitude and knowledge towards it. Because it is something that basically we all are getting older, and something that the elderly do worry about with respect to having falls. And a question that I would have would be, me as a general surgeon, and we all as physicians that are here that see these elderly patients, like, what kind of questions should I be asking them to look out for their fall risk?
Well, you can ask them, have you fallen within the past year? Do you have any concerns about falling? Do you feel unsteady whenever you're rising from a sitting position? Those simple questions are sufficient enough to help and screen for persons at risk of falls to see if they are low risk, medium risk, or high risk. Of course, if they answer yes to all of the questions, they would be considered considerably high risk. One question, however, is a yes to one of the questions, however, is sufficient for you to refer them for further assessment.
Dr. Bloomfield.
Hey.
Excellent talk, Dr. Longley.
Thank you, Dr. Bloomfield.
And I think people need to become a lot more sensitive, especially when you see elderly individuals, because, of course, they become a lot more fragile, feeble, and of course, they're on a battery of medication that can sometimes cause the effect of loss of balance, loss of ability. But another significant part, and this comes from my relationship with friends and relatives, is a lot of us live in homes where the bedrooms are on the second floor, and they mean climbing these stairs. I think people need to recognize the fact that as you grow older, it's probably time to either move downstairs or move into a different house, because
Indeed.
the falls going up and down the stairs can be traumatic and devastating. So that's my comment. Thanks for the talk.
Agreed. Thank you for your comment.
Thank you. Yeah. So a few comments. One from Dr. Forbes. Excellent presentation, very informative. Dr. Newbold, excellent and timely presentation. Nurses are extremely current in the fall prevention care and patients admitted to hospital. It is great to see physicians in the community are interested in fall prevention in the elderly. Sorry, Nurse Newbold. Thank you, Dr. Longley. And we'll move on to our next presenter.
Thank you.
Our next presenter is Dr. Lucas again, and he's going to present this time on mesenteric perfusion syndrome. Is a rare but significant complication of superior mesenteric artery stenting. Dr. Lucas.
Thank you once again. So it's a pleasure to talk about this interesting case, and let's get into it. So the table of contents. So we had a 51-year-old lady who had basically a 2-year history of postprandial lower abdominal pain. It was so severe that she basically would not eat, and this was associated with a 40-pound weight loss. She at that initial time, she had a proximal SMA stented. This was in August 2021, and despite immediate improvement in her symptoms, they recurred in December of that same year. Now, she had a previous history of ulcerative colitis and had been cured with a subtotal colectomy 25 years prior. She was hypertensive but well controlled on medication, and she did have a smoking history. So this is a CT scan from that initial presentation. And just to show you on the left, the celiac axis was actually chronically occluded. You can see this, I don't know if it comes up, but stenosis of the SMA. On the right image, which was an intraoperative, basically X-ray or fluoroscopy image, you can see the stent in place, the guide wire still in the SMA, beautiful deployment, excellent result. However, in December, when she started to have these symptoms and she later presented, I want to look at the CT scan, the sagittal on the right again at the screen. You can see that the stent has migrated distally, and there was still that SMA stenosis. So the assessment was SMA restenosis and a migrated stent, and the plan was to restent the proximal SMA. Again, accessing the left brachial artery, we're able to deploy express LD stent. You can see again, my sides mixed up, but the left side, you can see the previous stent inferiorly, and then superiorly, you can see they're about to deploy the proximal SMA stent. On the right is fully deployed. Good result. We started pat ourselves on the back. We were happy, but hours later, she began to complain of severe abdominal pain. Her abdomen became distended and tender. She wasn't quite peritonitic, but definitely we were all worried. She had a mild leukocytosis at the time, but her other labs were essentially normal. So the assessment was an acute abdomen, but what was the cause? We weren't sure if the stent had reoccluded, if there was a dissection that we missed, or maybe even a rupture. She was kept NPO. I started IV fluids and a heparin infusion just in case the stent had been occluded. We started antibiotics, and he gave her appropriate analgesia and ordered an urgent CT scan. So again, looking at the image on the left, you can see that the stents are patent, in perfect position, have not moved. On this coronal image on the right, you can see that the small bowel is a bit hyperemic, but well perfused. And in this axial image, you can see she has now developed bilateral pleural effusions. She now has ascites. What was going on? We weren't sure. So a lot of head scratching and debating about what was happening to our patient. We finally concluded that this was some form of ischemia reperfusion syndrome. And We continued with keeping her, they say MPO, ball rest, IV fluids, but recognizing that she was nutritionally depleted, not having really for months really. We had to start on a TPN and got an urgent general surgery consultation. During her post-operative course, she did have thrombocytopenia, acute drop in hemoglobin that we consulted hematology and gastroenterology for. They were negative. We noted that there was some splenic infarction, and we had to schedule her vaccines for that. And looking back on her case, the fact that she had ulcerative colitis before, the fact that if you look at the lesions, I'm just going to go back slightly. You can see that there's no atherosclerotic disease of the SMA. The stenosis, if you look back, there's some narrow stricture, but there's no plaques. So it's not atherosclerotic disease. So we entertained whether this could be a vasculitis presenting in this unusual fashion, and we got rheumatology on board. Really revealing nothing. And I must say, this came as a diagnosis of almost exclusion. If you look at the literature though, one of the things about this rare condition is that there are multiple terminologies used to describe this phenomenon. If we look at the current management of acute and chronic mesenteric ischemia, just look on the right side, you can see that endovascular revascularization is more common for the treatment of chronic mesenteric ischemia, and associated with lower postoperative major adverse events, 9% versus 27%, but higher rates of recurrence, up to 29%. So why do we do endovascular? Well, less short-term mortality and morbidity, lower in-hospital costs, but unfortunately, more reintervention. Patients have more frequent recurrence of symptoms with these procedures, up to 25%, and in some long-term studies, up to 40%. And when symptoms occur, they occur much earlier than in open surgery. Open surgery may be better for younger patients and those with non-atherosclerotic lesions, such as vasculitis, right? And consideration is whether that could have been the choice operation for this particular patient. Mesenteric ischemia reperfusion syndrome has been defined as the manifestations of hyperperfusion and ischemia reperfusion injury, typically after revascularization of the mesenteric circulation. We don't really know the incidence, and we're just trying to increase awareness of this condition. It's believed to be a complex process at the cellular and extracellular level with a number of identified inflammatory mediators. There's increase in pro-inflammatory cytokines, altogether leading to systemic inflammatory response and multi-organ dysfunction. Just at the level of the intestine, there's basically an ileus, there's increased vascular permeability, mucosal dysfunction, and sometimes bacterial overgrowth. Clinically, patients present with they can go on to develop ascites, pleural effusions, respiratory failure, as well as acute kidney injury. Diagnosis is one, beginning with ultrasound to assess for SMA patency. This may be limited, however, by the operator and as well as the presence of bowel gas. CT scan typically shows hyperperfusion of bowel wall edema, ascites, and pleural effusions. Care is predominantly supportive with bowel rest up to 72 hours or longer. TPN may be necessary, depletive therapy that is given, Lasix, other medications to help with the diuresis. Patients may also want to have a abdominal compartment syndrome, so you have to have a high index of suspicion for that. And in the resuscitating efforts, we try to avoid hypervolemia. There are a number of animal studies looking at drugs and medications that could possibly help with the reperfusion injury, but honestly, none has been proven beneficial in humans conclusively. So in conclusion, ischemia reperfusion syndrome is rare. You should still serious differentials such as stent occlusion or rupture or bleeding. Current management is really bowel rest and supportive care. Thank you for your time and open the floor for questions. Oh, I must say that we also have some other vascular surgeons in the audience. Dr. Nina Yap, just want to shout her out. Thank you for attending and participating in this meeting. Thank you, Dr. Major.
Yes, sorry about that. I just have to wait for the host to give me permission to unmute my mic. So yeah, great talk, Dr. Lucas. Truly appreciate it. And we have a couple of questions, and both of them are from Dr. Farquharson. And his first question was, does venous outflow obstruction, or was venous outflow obstruction considered? It is rare to have reperfusion injury in the vascular bed that was not occluded. And second question is, why did the splenic infarction occur?
Hi, Dr. Ferguson. Thank you. We never really found out why there was splenic infarction. One of the things was she had unusual anatomy where she had the occluded celiac axis, but then the gastric splenic artery were coming off of that occluded segment. The question was whether by reperfusing the SMA, there was some relative hyperperfusion to the spleen. There was also consideration of whether there was some embolization. And the third theory was whether this was part of some sort of vascular problem and had manifested with these splenic infarctions. We really never got to the bottom of it, and I would like to hear your take, or any other vascular surgeon or interventionalist, on what you think for that. In terms of venous outflow obstruction, I think it was considered with the triple phase CTA. We didn't see much evidence of that, like clotted thrombus in the venous system. However, it's definitely something that should be on your radar when you're thinking about mesenteric ischemia, as is one of the causes of mesenteric ischemia. You said you're rare to see reperfusion injury in the vascular was not occluded. Well, I mean, I think that's the interesting thing why we presented it. We submitted it for publication in a British journal, a medical journal, as well as in the Caribbean College of Surgeons. It is rare, especially for chronic mesenteric ischemia. It has been described in acute mesenteric ischemia a lot. It's quite like reperfusion in any vascular bed, like the lower limbs, and you reperfuse it and you have that injury. But for chronic mesenteric ischemia, is not well described. I can say it's not well understood. And hopefully, we can learn from this case, and I hope others can publish their experience and give their input so we can all grow from this experience.
Okay, great. I guess if no other questions, then we'll, oh, wait, great. From Dr. Yap, Nino, great presentation, Charles, interesting case. What's your imaging of choice to survey her stent patency going forward?
Thank you. Great question as well. The modality of choice is a duplex ultrasound. Where this case occurred, this was in Toronto General Hospital. They have an excellent vascular lab, and for most of our surveillance studies, as well as even diagnosis, is all done by ultrasound. We reserve CTAs for planning of surgery. So definitely for her, she'll more likely be followed up with serial ultrasounds. The other thing that I thought interesting about this case, and I'd like to hear your input as well, there was a chronically occluded celiac artery. And the thought, looking through the images, was whether this was some medium arc rate syndrome that had caused it. And one of the things I was thinking about was whether there may perhaps be some mechanical compression of the SMA as well, even though, again, this is rare and not well described. And that would have led to the migration of the stent initially, because we really couldn't explain why the stent migrated, even though it is a known complication. But given this lady, that was very unusual to have this very unusual complication. Anyway, thank you.
Thank you again, Dr. Lucas, for a wonderful presentation. Now, as we move on to our final presenter, I think we went through this pretty fast. This is Dr. Sally Griffith, as well as Dr. Carolyn Haynes. Dr. Griffith is a general advanced laparoscopic and bariatric surgeon who was trained at the Center for Advancement of MIS, Alberta, University of West Indies, and Imperial College in London. He pursued his internship in Cornwall Regional, and he did his fellowship or his residency training in Jamaica from 2000 to 2009, 2004 to 2009, where he completed the program. During this time, he took interest in laparoscopic surgery and did an elective as an honorary clinical fellow at Imperial College in London from 2007, at which point he was based at St. Mary's Hospital. While in fellowship, in the United Kingdom, Dr. Griffith did a diploma in laparoscopic surgery at the University of Strasbourg in 2008. He also spent a period of elective training in Spain under the tutelage of renowned laparoscopic surgeons at the Hospital de San Pau in Barcelona, University of Navarra in Pamplona, and the Hospital de University Ramon in Madrid. Prior to that, in 2005, he became a member of the Royal College, and in 2000, basically his fellowship was accredited by the American Society of Metabolic and Bariatric Surgery in May of 2012, and presently he's at the University of West Indies Cave Hill campus doing general surgery. As of August 2020, Dr. Griffith was appointed as head of the Department of Surgery at the Queen's Elizabeth Hospital and still holds his post. In 2021, he became director of the Caribbean Colon Cancer Initiative, which is a research-led nonprofit organization focusing on colorectal cancer in persons of African descent. He has used this platform to aid surgical trainees in various research missions and advancements of their surgical skills. Dr. Carolyn Haynes graduated from the University of West Indies Cave Hill campus in 2021. She would have completed her internship at Queen Elizabeth Hospital last year, and she is currently acting as a junior research fellow of the Caribbean Colon Cancer Initiative. Let's welcome them to the podium.
Thank you very much, Dr. Major. Yeah, and I really appreciate being allowed the opportunity to present here, because in truth, the research done in Jamaica with regards to BRCA gene, in Bahamas with regards to the BRCA gene, is actually what made me realize that, in a sense, we in the Caribbean really are sitting down upon a wealth of information through our genealogy that allows us to basically analyze why we are having some of the conditions in the diaspora that we are having. And I really appreciate y'all guys out in the Bahamas for having done that cutting edge work, you know. Dr. Haynes, I would like her to be able to present what we've been doing on combined endoscopic laparoscopic surgery, and I welcome any questions at the end. Dr. Haynes, over to you.
So good afternoon. As Dr. Griffith would have said before, I'm one of the junior research fellows of the Caribbean Colon Cancer Initiative, and it is my honor this afternoon to present alongside Dr. Griffith on the topic, a review of the outcomes of SELS procedures in a low resource setting. Okay. So colorectal cancer is the third leading cause of cancer-related mortality in Barbados, and public education and promotion of screening are key to the reduction of mortality rates, as well as reducing the morbidity associated with the disease on the island. Colonoscopy is recognized as the gold standard screening tool for colorectal cancer, and is not only useful for the detection of precancerous lesions, but also useful for their removal. However, some larger polyps may pose some challenges for the endoscopist to be removed, and persons may find themselves being referred for surgical management of these lesions. Previously, colonic resection was the method of choice for removal of these polyps that were more difficult to remove at the time of endoscopy. Combined endoscopic laparoscopic surgery has, however, arisen as a viable alternative. At the moment, the technology which is necessary to perform these procedures is available on island. However, previously, the expertise was lacking. Recently, we've got some surgeons who are able to perform these procedures have been performed on island, and we've reviewed the outcomes of those procedures. So before I move on, what is combined endoscopic laparoscopic surgery? Combined endoscopic laparoscopic surgery involves a combined approach using both laparoscopic surgery and colonoscopy, and acts as a viable alternative to colonic resection in select patients with polyps which cannot be removed endoscopically. In order for us to select these patients, a good patient history and examination are critical. These techniques should only be performed in patients with benign histology, and caution should be exercised when these persons have high risk for colon cancer, such as having a family history. Previous surgery and morbid obesity should also be taken into consideration prior to performing these procedures. So there are various cell techniques. The cell technique which is used most frequently in this study is the laparoscopic assisted polypectomy. Full thickness laparoscopic endoscopic excision is also utilized in this study. There are also two other cell techniques, full thickness cells as well as endoluminal surgical intervention. Laparoscopic assisted polypectomy is actually the oldest technique which is described and is in most widespread use. It involves the use of an endoscopist along with an abdominal surgeon. The role of the endoscopist is to first identify the lesion and confirm its location and size prior to beginning the procedure, as well as to look for any features that might be suspicious of cancer, such as hardness, depression, or ulceration. The cells involve the insertion of an endoscopic injection needle through a working channel of the colonoscope with utilization of either a dye or albumin or saline to not only mark the location of the polyp, as well as to raise the polyp off the muscular layer of the colonic wall. The joint efforts of the laparoscopic surgeon and the endoscopist assist with the removal of these complex polyps. What the abdominal surgeon does is reposition the colonic wall to help expose lesions that otherwise may have been hidden at endoscopy by mobilizing segments of the colon. And if there is thermal energy utilized, and thermal energy is often utilized, and the abdominal surgeon is able to examine the serosal side of the colon, and if there's any injury, able to reinforce the site. Flex technique is also another method which is frequently used to target lesions on the right side of the colon. Oftentimes, lesions that are close to the ileocecal valve are involved in the appendiceal orifice, which might be a bit more difficult to target using laparoscopic assisted polypectomy. Similar to laparoscopic assisted polypectomy, first the location of the lesion is confirmed via endoscopy, as well as ensuring that there are no lesions at the time of surgery which are suspicious for cancer. Abdominal entry is then performed. The cecum and ascending colon are mobilized along Tolt's line with an ultrasonic device. The appendix is then dissected sharply off the terminal ileum, and using a combination of endoscopic and laparoscopic techniques, the margins of the polyp are delineated on the surface of the cecum. The lesion is then resected and blocked with the appendix. The staple line is tested with a dye, and then the specimen is moved via via, in our case, the umbilical port. I'm not going to go into too much detail regarding this, but this is a slide demonstrating steps in full thickness cells. And in the luminal surgical technique, this is actually the newest technique in use, and it involves interventional endoscopists utilizing similar techniques, utilizing the management of upper GI lesions, such as endoscopic mucosal resection and endoscopic submucosal dissection to manage these complex colonic polyps. What are the benefits of cells procedures? So the benefits of cells are financial, they save on time, and there are also benefits in terms of bowel preservation. So as is important in a low resource setting such as Barbados, cells procedures are associated with significantly reduced costs. While the equipment costs tend to be slightly higher than that for laparoscopic or open resection, it has the benefit of being an outpatient procedure, which saves on time, and that helps to save on money as the patient isn't going to have those long stays in the hospital, as well as very low complication rates in comparison to colectomy, with complication rates being reported as low as 4%. An analysis done by Sharma and Nakajima et al. Identified the total cost per cells procedure at $6,554, which compared favorably to $12,585 for laparoscopic segmental resection and $18,216 for open resection. A systematic review by Lewis, Johnson et al., where medical databases were searched to identify English studies between 2010 and 2019, containing an economic evaluation of postoperative complications following colonic resection in adult patients, also found a high overall complication incidence with associated increased costs ranging from $2,290 to $43,146, with surgical site infections and anastomotic leak being shown to be associated with the highest resource utilization. Another benefit of cells is bowel preservation, which is important for the maintenance of fluid and electrolyte balance. So 8 patients were identified for our study, and these procedures took place both in the public and private sector between 2020 and 2022. All cases had been managed by the same surgeon. A list of patients had previously been compiled with an aim to audit these cases in the future. Patients identified were between the ages of 50 and 83, and the mean age was 66 years. Most patients have been referred from their GI specialist following identification of a polyp that was too difficult for them to remove. In all cases, the polyp had been biopsied at the time and benign histology was confirmed. The majority of the lesions identified were right-sided. In most cases, 75%, laparoscopic assisted polypectomy was the cells technique of choice. In only one case was full thickness endoscopic excision performed. And in one case, the cells had to be abandoned at the time of surgery due to small bowel dilation. So at this time, it has to be noted that one of the limitations in our setting is actually the use of air insufflation rather than carbon dioxide for endoscopy. For cells procedures, carbon dioxide is the preferred gas for insufflation, as it has the benefit of rapid reabsorption, especially from the small bowel. And bowel that is too dilated actually makes cells techniques quite difficult to perform. In addition to that, carbon dioxide insufflation also has the benefit of being associated with less abdominal pain and distension post-operatively. So this is a slide that's actually showing the initial findings on colonoscopy. So we can see that there were a range of indications for screening for range of indications for initial colonoscopy, with screening being the most dominant reason. And findings were all benign. So we had tubular adenomas with low grade to high grade dysplasia, and we also had tubulovillous adenomas with high grade dysplasia. And we can see that the majority of these lesions are actually located on the right side of the colon. So we don't believe that these lesions being on the right side is necessarily saying that in our population, the majority of lesions are right-sided. We actually have some research coming out of the group that suggests that the majority of lesions are left-sided. In reading what seems to be the likely reason for the majority of lesions being right-sided is that right-sided lesions tend to pose more difficulties, especially those closer to the cecum and appendix or ileocecal valve tend to pose more difficulties for the endoscopist to be removed as opposed to left-sided lesions. No complications were reported, and after initial review post-operatively, referrals were made to the patient's gastrointestinal specialist. No referrals were made. The recommendation is that based on the patient's histology post-operatively, screening be adjusted to suit. So what conclusions can I draw or can be drawn? The number of benign polyps that are found to be unresectable at endoscopy is expected to increase as colon cancer screening becomes more widespread on the island. Combined endoscopic laparoscopic surgery has been proven based on literature and based on our research to be a safe and cost-effective method of managing these polyps, and there would be benefit to devoting resources to educating current surgeons who are willing, as well as persons in surgical training in these techniques. Thank you. And these are my references.
Thank you, Dr. Haynes and Dr. Griffith, for that excellent presentation. I'd like to also thank you guys for pioneering this new technique here in the Caribbean. And it's something that, you know, us as general surgeons, we're kind of originally thought that, you know, you don't do a colonoscopy same time as you're doing a laparoscopy, and now you guys are showing us that it can be done, especially in those cases where you have benign pathology, because we end up resecting a lot of these individuals for benign adenomas. Let's see if we have any questions from the group. I guess a question would be, when you do, yes, you said you've only done one full thickness. Most of them have been mucosal or submucosal. And let's say you've done a full thickness one. How long do you generally keep them in the outpatient facility? Do they go home the same time as somebody who've done maybe submucosal? And you know, what's the kind of follow-up for that person?
All right, thank you very much for that question. Very gentle people. I am on call, so I'm on my way to the hospital. Yeah.
Understand.
I would say though, yeah, I would say that the truth is, it really, for me, we keep them in the clinic depending upon the histology. So we get the you would see there were a couple of high-grade dysplasias there. Those I would repeat the colonoscopy in a year. Yes. And normally once you don't say anything, high-risk individual. Realistically, because if it was a malignant lesion, realistically, we don't get the SM levels here because you don't know, and the possibility of lymph node spread depends on how deep it goes in the submucosa. If malignant at all, I would then proceed to a laparoscopic colectomy. You see, and I think we would lose very little because realistically, we have not had a perforation. We've stapled off the bowel edges. But all of ours, thankfully, so far have been benign. And typically, we would look at them on the scope. Yes, if I came to it and I looked at it on the scope and I look, boy, I doubt it, I would just come out, you know what I mean? If it is that I believe that it is, it looks to be benign, you know, you would try and see what can happen for the person, you know, especially if the histology up front suggested that it was benign.
Okay. And the endoscopy portion of it, who does the endoscopy? Is it a surgeon or a GI physician?
Man, listen, when I first put in the endoscope, my anesthetist was very comfortable with flexible bronchoscopy. So once I get to the lesion, he could twist it. Yeah, and so ultimately, what he would then do is use his ability to stay on point and my ability to use it. I have to scrub over, go back in now laparoscopic and do the stapler. But as you know, and one of the things that Bahamas has really taught us in the region is that when you get fellowship trained persons, it's better you get them in pairs. So I know that Wesley went on this and then he was able to basically have skills coming together. Same thing I know with Dr. Ferguson and Dr. Lucas, and I give thanks for the example that Bahamas has given to the region. But in that regard, I now have with me in Barbados here Dr. Shabir St. John, who is a colorectal surgeon trained in the University of Toronto. And so the last one I did, we did it in the public setting, and he was able to do the endoscopy, and I did the laparoscopic portion. And I'm sure his skill set is such that sometimes I can do the endoscopy and he can do the laparoscopic portion. So as you get more persons together who have the skills, what you can do is optimize outcomes, you know?
Awesome.
And this is what we need to encourage more in the region, I think.
Hi,
Yes.
Don.
We agree. Hey.
Yeah, Shabir here. So, further to what Dr. Griffith has said, and this may be slightly more controversial, but I think something worth discussing is that in the appropriately selected patient, lesions that are likely to be malignant or even confirmed to be malignant can also be tackled in patients who you think have poor, functional performance status, and you think it's more worthwhile to do a limited colon sparing resection for them to remove the lesion, because the risk of lymph node spread being low on imaging, and then if they have favorable histologic features such as no lymphovascular invasion, no tumor budding, these are the kind of patients that you can actually extend. So it's a more of a relative indication of cells. I mean, the absolute indication, as Dr. Haynes would say, is benign histology or something that's likely to be benign, but we can extend it for those patients who really are not fit for any kind of colectomy and who an anastomotic leak might be fatal for them. So I think you can also include them in your cohort, but obviously you would have had to have had a discussion with them, a robust discussion with them and their family about the risk. Because if you have low risk features in an in situ carcinoma, the risk of lymph node spread is less than 5%. And so then therefore the risk of metastases or recurrence is very, very low as well. So that's just something to add.
Okay, thank you. Thank you for that. And thank you guys for the work that you're doing. And I look forward to hearing more about it. So I guess if there are no more questions, my segment now comes to an end.